and then take them. Okay.
Sorry, Dr. Shah, that was me. I apologize.
That's fine. So, then the other thing is this viral shedding and the transmission. Usually, the illness, it about takes 7 to 10 days. Like we can call that the incubation period. Once you probably are infected by the virus or you have had a dose of the virus through cough or sneeze, it may take 7 to 10 days to start the illness to start. Now, so this is something about transmission that I wanted everybody to understand. So the hospitals have put these special fans in all the rooms, and a lot of changes have been made so to improve the air quality and to decrease transmission in the hospitals. One thing which was extremely scary about this virus was that asymptomatic patients can transmit. So this is the reason the virus spread so quickly, because a person who did not have any symptoms would go into a large area and he would basically be either coughing, sneezing, or even just breathing or talking. The saliva has these tiny droplet particles of the saliva would be suspended in the air with the virus on it, and that would cause the transmission to people. During our initial work in the ICU, we remember that the nurses had become so scared that if we would come out of the room and not take off our PPE properly, they would write a report against the physicians. This is how scared people were initially. This virus is also transmitted through environmental contamination. So this is the reason hand washing is very important, because the virus can stay alive on handles, light switches, and all kinds of surfaces. And the CDC had a special report on this about what is the survival of this virus on different kinds of surfaces. And on a plastic dry surface on room temperature, the virus can survive for 9 days. The virus is inactivated by ethanol, sunlight, high temperature. So initially, when we were told that we do not have enough N95 masks and other masks, so I would put my N95 mask in the car, and the car was closed, and just from the heat of the sun, we thought the virus would be killed. And I think that was probably true, because during this whole 11 months when I was on the COVID team, and I had a colleague, she was infectious disease, and we were the only people who were entering the room of the patients, because all other physicians refused to enter the rooms. And they had said that they will copy our physical examination onto the progress notes and histories and physicals and all, and consultation notes. Then at that time, we never got infected, and my colleague, she also never got infected. And I think that was because we were very careful in how we donned and doffed our PPE. So donned and doffed are the terms which came out for PPE, which is how to wear the PPE and how to take it off. So basically, we had already started wearing scrub suits, and to get into the room, I think in most countries and even in Pakistan and everywhere else, they have been following these rules. So you wear plastic gown, and you would wear a face shield. Underneath, you would have an N95 mask. You would have gloves, and with that, you would go in the room. Later on, we had special equipment which came after about, sorry, turn this off. it came after about 6 months. That is called PAPR, which is a special kind of a hood, which is connected to a fan with a filter on it, and the air is blown through the filter and then gets to you, so you do not get any virus from the environment. As far as transmission is concerned, animals can also be carriers, and there have been reports here that dogs and cats were carriers of this virus, and dogs and cats have a major importance in the Western society. So people would not stay away from their dogs or cats or taking them for a walk, and then they would get infected through these transmission through their pets. Okay, so coming to this virus, once you are infected with it, you get two kinds of responses, immune responses. Humoral immunity, which is serum antibodies, and then you will develop cell-mediated immunity, which is CD4 and CD8 T cell responses. This virus also is very peculiar in the sense that people who have been infected and get the disease can also get reinfected. Reinfection risk is low. Usually there is a protective effect of the infection, of the first infection, which is about 80%. So it's a, if you have 10 people and they get reinfection, or they get another dose of the virus somehow from the environment, 80% of them will be protected, only 20% would get the disease. In this context also, there's another thing important, is what is called the R naught. R with a small, tiny kind of a zero on it is the symbol for it. R naught is basically the infectivity rate of any virus. So we should thank God that COVID does not have an R naught like measles. So measles is so highly infectious that if a person, a boy or a child or a girl who has measles, they walk through a school, they will give measles infection to everybody, almost everybody in the school. It's like the R naught is something like 300 to 500. It can be that high. So the R naught of Corona, when we had initially gone into the epidemic, was 5. So what it means is one person can give it to 5 people, and each and every person in those five in the group of 5 will give it to 5 more. So that's an exponential rise in infection. The R naught later on in America, and especially I remember in New Jersey, had dropped to 2, and once it got to around 1.2, 1.1, we were very happy, and we knew that things were getting in control, much better. Once you're exposed with the virus, can you get or take something? In America, there's a medication called Regen-CoV, R-E-G-E-N, CoV, C-O-V, which is casirivimab dash imdevimab. That can be given, but we have hardly ever used it, but it is available, and it can be given to people who have been infected. So say somebody goes to some kind of an event, a lot of people are infected, the person somehow finds out because other people are tested, they would be a candidate to get this medication.
Dr. Shah, just excuse me if you don't mind.
Sure.
2 things. अगर आप मुनासिब समझें और इस किस्म की मेडिकेशन को maybe text पे आप डाल दें while you are describing the names of those medications, it would be helpful for participants to note it down. Or okay. 2, maybe मेरा ये शायद microphone I'm sorry system ऐसा होगा लेकिन आपका शायद कैमरा थोड़ा सा शेक कर रहा है।
Okay.
तो बस ये दो चीजें थी।
Okay.
थैंक
Sure.
यू सो मच।
All right. मेरे ख्याल से मैं when I think I move my computer, then I think the computer का camera भी फिर move करता है. I think that's what's happening. Yeah. All right. Let me see. Okay. इसमें the other thing is who to test. So it was at one time recommended to avoid testing asymptomatic individuals who previously got the COVID infection. So everybody else is tested. Like for example, people who are working in the healthcare industry, they are all tested. People who are going to travel, they are tested. People who are going to go into some kind of a work facility, they are tested. All those people are tested, but the recommendation is not to test people who are asymptomatic and have previously been diagnosed with SARS-CoV-2 within the last like 3 months or something like that. The tests that are done are nucleic acid amplification test, where a reverse transcript polymerase chain reaction. What happens is you take the sample and it is amplified multiple times, and then they're able to detect the virus. False negative tests are possible. We always check the nasopharyngeal secretions. A swab is taken and it's put into the nose, and that's the way to get the swab. There are some other ways of doing it too, like gargling or spitting into a tube. Those things are also done. The rapid tests are less accurate, that's for sure. Then there are the antigen tests, which also detect the SARS-CoV-2 antigen, serology tests, which detect antibody, the IgG antibody. Viral cultures are not done. By viral culture, we mean, say if a specimen is taken and put viral culture, like we
डॉक्टर शीना, आप अपने आप को म्यूट कर लीजिए प्लीज।
Dr. Sheena, Dr. Sheena, can you mute yourself?
Yeah, I took care of her. Thank you. Sorry about that.
Acha. So viral culture is only used for research purposes. So CDC, NIH, they are the ones who basically do viral cultures. Viral cultures are not done in the regular setting. Acha. Now comes something interesting, is disease severity. I think this is probably one of the important things that I want to talk about. So symptoms wise, what happens in the patient? So patient will have, if it's a mild disease, patient is going to have fever, malaise. Malaise means you just don't feel like getting up. You are tired, and you know what happens with most, like flu, cough, and upper respiratory symptoms. Now in upper respiratory symptoms, it's interesting what kind of symptoms. So basically you will have nasal congestion, unable to breathe easily through the nose, secretions in the nose, nasal congestion. Those are the upper respiratory symptoms. But there will be absence of dyspnea. This will be mild. So dyspnea is the feeling of having shortness of breath. You are feeling short of breath. That feeling is called dyspnea. DYSPNEA, we know that, right? So as medical professionals, if you have moderate disease, you have all of the above, which is the fever, the malaise, the cough, and the upper respiratory system, but you are also going to have dyspnea. Now, dyspnea is extremely important here. This is a very small similar thing. So I think मैं इस वक्त उर्दू में आता हूँ। तो आपके पास कोई मरीज आता है and वो कह रहा है कि मुझे मेरा ख्याल से कोविड हो गया, ठीक है ना, घर में है, फैमिली मेंबर है या कोई भी, सो आप उससे पूछें कि भाई आपको क्या बुखार है, आप थकन महसूस कर रहे हैं, आपको खांसी है, आपको नाक में ऐसे महसूस हो रहा है जैसे सांस नहीं लिया जा रहा, तो वो कहते हैं हाँ मुझे ये सब कुछ है। तो इस बंदे, इस शख्स को, खातून को या मर्द को, इनको माइल्ड डिजीज है। लेकिन आप पूछे क्या तुम्हें सांस चढ़ रहा है, क्या तुम्हें सांस में मुश्किल है, क्या तुम्हें ये महसूस हो रहा है कि तुम्हें सांस नहीं आ रहा, यह सांस लेने में मुश्किल हो रही है, इसमें जो सबसे सिंपल क्राइटेरिया वो ये भी है, चलते हुए में क्या महसूस हो रहा है या सीढ़ियां चढ़ते हुए में। अच्छा, अगर कोई शख्स ये कहते हैं कि मुझको वन फ्लाइट ऑफ स्टेज, एक यानी कि एक फ्लाइट ऑफ स्टेज होगा 10 या 12 सीढ़ियां जो एक एक मंजिल की होती हैं, अगर वो चढ़ने में दुश्वारी हो रही है तो इसका मतलब है कि बहुत सिवियर डिजीज है, अच्छी खासी सिवियर है, मॉडरेट से ज्यादा है। क्योंकि सर्जरी में जब हम सर्जिकल क्लियरेंस करते हैं फॉर रेस्पिरेटरी सिस्टम, तो वन ऑफ द टेस्ट जो कि acceptable है in America is a stair climbing test, which means कि if a person can go up 5 flights of stairs, that person is in excellent condition. 5 flights means 5 stories. जैसे आप कहेंगे 5 मंजिलें, अगर कोई 5 मंजिलें चला जाता है तो that person can go and have any kind of surgery without any problem. अगर वो शख्स एक मंजिल चढ़ने में मुश्किल हो रही है then he has a problem. So similarly, इस situation में moderate would be a person who has dyspnea and has signs of dyspnea. So that's it. अच्छा, अब severe कैसे आप distinguish करेंगे? Severe में ये होगा कि जो oxygen saturation है, which is the percentage of oxygen in the blood, which is detected by a very simple instrument, pulse oximeter, that would be less than 94%. And if somebody has less than 90 or then it is critical, less than 88% is very critical. And severe people need oxygen or they need some kind of a ventilatory support. Now, ventilatory support, it's very interesting. There are a number of things that can be done for the patient. So let's start with the basic. सबसे simple चीज जो होती है, that is putting somebody on a nasal cannula. अच्छा, in this slide segment अभी मैंने slides वगैरह नहीं बनाई हैं because I think most people are familiar with these things, so इसलिए, but if people wanted we could send pictures also later on. But basically nasal cannula is a tube which goes right here. उसमें दो छोटे से ports होते हैं to go into each nostril. फिर mask है. Mask में there are different kinds. जो सबसे intense mask होता है वो that's a non-rebreather mask, जिसमें के 100% oxygen दी जाती है, and then there is a small bag जो कि reservoir होता है. So continuously you are getting 100% oxygen. So that's one of the other ways of giving oxygen. Then there is the non-invasive positive pressure ventilation. That is a very tight fitting mask on the face or just the nose, or it can even be a full face which covers the whole face, but it is extremely tightly put in, and it's non-invasive positive pressure ventilation. Two kinds of methods are used with that. One is the CPAP and the other one is called BiPAP. Or that in itself would be a whole lecture, I think, on ventilation. But the last stages, so say you put somebody on nasal cannula. Nasal cannula पे oxygen usually is available up to 5 liters, but you can even go up to 15 liters. 15 liters would be 100%, but 15 liters usually is easily more given by non-rebreather masks. Acha, say you try that, that doesn't work. You initially in America, because of the concern of aerosol, we were told not to use non-invasive positive pressure ventilation. And यहाँ पे एक नई category भी आ चुकी है, which is called high flow nasal cannula, which probably will be available in Pakistan in the hospitals too, which is another nasal cannula, but it's tighter fitting and it can give oxygen under pressure. High flow nasal cannula initially in the pandemic was not allowed, but later on now we have been using it and it has been really very effective. Initial में concerns बहुत ज़्यादा थी aerosolization की. So in the hospitals, all procedures which cause aerosolization, so nebulizer treatments, which means you have the bronchodilator in a small tube and it is given through an ultrasonic nebulizer machine, which creates vapor and the patient is inhaling, that were all discontinued. People were only getting the meter dose inhalers. Meter dose inhalers, you probably already know. These are the small canisters with high pressured medication and people press and they take. Actually, I don't have a sample right now, but otherwise I would have shown it. So those were being used, meter dose inhalers, during the pandemic. Then the last stage would be ventilator. So, and when do you decide? I think I'm going to talk about that a little bit also. Like, when do you decide to put somebody on a ventilator? And why, what do you have to do once you put somebody on a ventilator? So let me talk about a little bit about outpatient management before we go on to other things. So outpatient management may, so if we had this person who is coming to the clinic and we are thinking he's got COVID-19, he had testing done, he's COVID-19 positive, we'll check, we see that the patient has dyspnea, we will check oxygen saturation. So oxygen saturation ke liye, all doctors probably can buy this for their clinics or for is a small device called a pulse oximeter. It's America makes about $40 to $70, $60 mein milta hai. I'm not sure Pakistan mein iski kya price hogi, but it's a very simple device. It gives the pulse rate and the oxygen. It's got an electronic system where the light goes through your fingernail and through your finger and it picks up how much oxygen is attached to the hemoglobin, and it's a wonderful device. It's a wonderful device. So then the question comes, so if the person is short of breath, saturation is less than 88%, we would decide to probably consider giving oxygen. And it depends if the oxygen can be given at home in certain situations, but most of the time people do get admitted to the hospital. Outpatient people who are not very sick can also get monoclonal antibody therapy. And monoclonal antibody therapy has been given to hundreds of patients, elderly people who have some kind of a risk factor. They are not very sick. They do not require oxygen at high doses. Those people have been given monoclonal antibody therapy. And this is an infusion which is done in an outpatient setting. And the patient gets the infusion over 1 to 2 hours and then they go home. Non-hospitalized patients, patients who are not hospitalized, do not require glucocorticoids, which means steroids. Unko, the current recommendation is not to give them. Dexamethasone is the one drug which has been used the most, and dexamethasone could be given and can be given sometimes to people who are hypoxemic, but usually in outpatient setting, we are not giving patients steroids. There was a major controversy in America where you might have heard of this, was hydroxychloroquine. Should we give that or not? Or chloroquine should be given or not? This is a malaria medication which was being basically, a lot of people were pushing this medication, including the president. But hydroxychloroquine and azithromycin are not considered beneficial. This is the current analysis that they should not be given. There's another medication called fluvoxamine that is being tried, and some physicians have been giving that medication in outpatient setting. I'm going to talk a little bit about inpatient management. Inpatient management. So once the patient, it has been decided, patient has a severe desaturation, they are going to be admitted. What are the tests that are done? So basic lab work, definitely you would do like CBC. Then there were some markers which were being done, which included ferritin, LDH, CK, CRP, D-dimer, PT-PTT. And then there is something called the procalcitonin. Now, procalcitonin is not specific in COVID, but basically, why would you do that? You are trying to figure out if this person has a bacterial infection on top of a viral infection. So most of the time we were not using antibiotics empirically, which we use for pneumonia in COVID-19 patients. So you had to have some kind of a suspicion that the person also has a bacterial infection. So this could be high white count plus secretions which have a specific color, or person on the chest X-ray shows consolidation and there is fever, person has been maybe a smoker. Some of those things would make you think, okay, this guy probably has a bacterial infection, and you would put antibiotics on top. So what would you use is maybe in a simple case, you could use just azithromycin, but you could otherwise, if you are suspecting a more severe disease, you would either give a combination, ceftriaxone plus azithromycin, or if the person you're suspecting has secondary has maybe resistant infection or was given antibiotics previously, you would want to do something like zosyn, which is piperacillin / tazobactam. So that kind of an antibiotic would be used. You would check arterial blood gas on the patient. And arterial blood gas is a very good tool that we have, and what it tells us are three main things. You have the pH, which tells you the acid-base balance. It tells you if there is a respiratory problem, if there is a metabolic problem, and is it an acidosis or is it an alkalosis? Second thing you get from it is the CO2 level, PaCO2, which is the P capital A small and CO2, which is the arterial content, carbon dioxide content. And that tells you about the ventilation. Is the person ventilating properly or not? Because these are a little bit different, ventilation versus oxygenation. And next thing would be the PaO2, which tells you if the person has hypoxemia or not, which means there is enough oxygen in the blood or not. And if the oxygen is low, the person is having a problem with oxygenation. So that's the important thing about the blood gas. So the normally pH is 7.40, PaCO2 is 40, PaO2 should be more than 66 or 70, maybe some labs would say 70, but we can say 66 or 70 and or higher. So if you have a person who has low PaO2, that person is not oxygenating well. If a person has high CO2, that person is not ventilating well. So these are two different things. So oxygenation means the barrier. There is a barrier between the oxygen getting absorbed into the blood. So the lung consists of tubes at the end of which are alveoli. They are exactly, you should consider something like grapes, or very, very tiny, minuscule, microscopic grapes. So the grape is an alveoli and it's hollow. Air is coming through the tube. It's getting into the grape. This grape is a small balloon. It expands, and the oxygen is absorbed from the surface, inner surface, into the blood. If there is a problem, then you would not be able to absorb the oxygen. Now, PaO2, once you see that the number is low, you would have to, on the blood gas, you will give person more oxygen. But usually we do not do blood gas regularly. We check oxygen saturation and we monitor the patient's oxygen level just through oxygen saturation, which is the pulse oximeter either on the finger, earlobe, or in some cases, this probe is attached to the forehead. It can also be attached to the toes, anywhere. And you're checking the oxygen saturation and monitoring. And if the oxygen saturation is dropping below 90%, you go up on the oxygen. CO2 level, the CO2 level, which is basically telling you about the ventilation, basically tells you if the person is ventilating. Now, ventilation is totally different. Ventilation means, is the person taking enough breaths? Are they deep enough? Are they strong? And ventilation would be low in people who have some other problem, like a neuromuscular problem, somebody who has muscle weakness, respiratory muscle weakness, which could be from neurologic disease, infectious disease. There are certain infectious diseases which cause that too. And the CO2 also basically tells you that the person is tiring out, fatigue. So let's go. So आपने किसी की arterial blood gas करी है और 3-4, आपकी PaCO2 जो थी वो है 44, PaO2 उसकी है 70. अच्छा, person is oxygenating okay, not very good, but आप देख रहे हैं कि PaCO2 उसकी 44 है, जो कि हाई है. 40 is normal. लेकिन अब अगर यही ब्लड गैस रिपीट की जाती है आफ्टर 1 hour, 4 hours, or whenever, and CO2 has gone up, that means, or pH जो है वो और lower हो गई है, तो that means the person is probably tiring out. He cannot ventilate. This person is tiring out. So आपको, now I have to say something. Now I'm going to tell you, which is really important, is experience and what being a physician is basically. So everything, all this information is written in the books, and the difference is basically between a student and somebody who's practicing is the experience. So when I walk into a room, I can look at a person and I will say, intubate the patient. Or if they bring me a blood gas and they tell me, and I will ask a few questions, I will say, intubate the patient. So either I have to say something very interesting. A long time back, I remember one of the cardiologists had put out, he was a Filipino, very famous cardiologist, Campos. in Buffalo, New York. He had put outside his office a paper on which was written to cat the or not to cat. So वो Shakespeare से उसने वो चुराया है, to cath or not to cath. So if you are a cardiologist, basically you're deciding, okay, do you want to cath or you want to not do the catheterization, coronary catheterization. So in pulmonary, it would be like to intubate or not to intubate. So that's the question. So itne saal, when you study for such a long time, you become a doctor, then you do pulmonary critical care and all that. Basically, you are coming to a level where at the end, basically, you just have to answer this question: to cath or not to cath, to intubate or not to intubate. So which would be, is this person that sick? Should we put him on the ventilator? So this arterial blood gas is one of the tools that you use to know that you will intubate the patient, put the person on mechanical ventilator, and give him support. Mechanical ventilator is a support. So there is this one question that a lot of people asked us, families and friends, oh my God, don't put my mother on the ventilator, she will die. Oh, we have been told if you put the person on the ventilator, this person is going to die. No. So then we had to explain to the families, ventilator is a support. Ventilators do not kill. Ventilators save people. Ventilators are there to help you. Ventilators are there to help you in the bad time when you cannot breathe on your own. They give you the support, make you stronger, and then you do. Very interestingly, one of my cousins got COVID in Faisalabad. और उनकी फैमिली का मुझे फोन आ रहा था और क्वेश्चन था कि क्या करें. He was a heavy smoker, COPD, and फैमिली के लोगों ने और कुछ यंगर डॉक्टर्स ने भी मुझे कहा कि जी हम इनको वेंटिलेटर पे नहीं डालेंगे. मैंने कहा अच्छा क्यों? मैंने कहा जी वेंटिलेटर पे हम इसलिए नहीं डालेंगे क्योंकि वेंटिलेटर पे डाल दिया तो जो भी वेंटिलेटर पे जाता है वो मर जाता है और वेंटिलेटर जो है उसका मतलब बेसिकली डेथ सेंटेंस है. That's actually wrong. We had people on the ventilator. Yes, a number of people died, but a lot of people survived because ventilator is a support system, and basically it helps people gain the strength to get back to normal. Oh my God, I'm moving my computer too much. So that's the thing about, so ferritin, LDH, CK, CRP, ये जो थे, ये initially during the first surge, we were following them like crazy. Every day we were doing ferritin, LDH, CK, CRP. And we were discussing during the rounds, today ferritin is 1200. Oh, tomorrow, yesterday it was 1100. LDH is this, LDH was that. Every day there was a discussion. CK is high, CK is low, CRP and all that. We're not doing them anymore. We are doing them very rarely. We are not really following them daily. Ferritin, LDH, CK, CRP, we are not following them. D-dimer is important. D-dimer tells you if the person has more thrombosis, and that one is really important, and so is PT, PTT, but mostly D-dimer, because one of the major complications of COVID has been thrombosis, and D-dimer tells you if the person is more prone to thrombosis. And thrombosis, we have seen patients develop stroke and other problems. So those people who have high D-dimer, they need to be put on full anticoagulation dose. Lovenox, full anticoagulation dose, not prophylactic dose. So prophylactic dose is very low, like 40 milligrams sub-Q daily is the prophylactic dose for Lovenox, which is used to prevent DVT in hospitalized patients. We would use full dose in a person who has a high D-dimer. All right, so that's about that. Radiology, chest X-ray. Okay, so let me talk about a little bit about chest X-ray. How helpful is chest X-ray? If you do one chest X-ray and you see there is a lot of airspace disease, both sides of the lungs, yes, this person has viral infection, viral pneumonia. If you see some consolidation, he has on top of that bacterial pneumonia. So chest X-ray is helpful. Do you need to do daily chest X-rays? No. Do we do daily chest X-rays in ICU? Probably not. We don't. So most hospitals will not now do daily chest X-rays except when people are intubated. So they may have a protocol because you want to make sure that the endotracheal tube is in the correct position. But otherwise, non-intubated, non-ventilated patients, chest X-ray should not be done daily. CT scan has little significance. And one thing that I was very shocked on, when I used to be in Dow, at that time, CAT scans to I ही नहीं थे Pakistan. But later on, even I knew that there were very few people or few hospitals which had CAT scans. And now it is unbelievable that CAT scans are done in Pakistan like on the drop of a hat, daily, and a lot of CAT scans are done. So CAT scans, unfortunately, I think are being overused, and CAT scans should not be done regularly, and I know they are very expensive for the families also. And I really don't think CAT scans have much to help or do help much with COVID-19. So what other treatments we are doing? We talked about oxygen. Remdesivir. Remdesivir is the antiviral medication, 200 milligrams on day 1, 100 milligrams for 4 more days. And we could make the course from 5 days to 10 days and give another 5 days in some situations, but usually just 5-day course. Then we have the immunomodulators, interleukin-6 receptor antagonists. There are 2 of them. Actemra, which is a single dose. Tocilizumab, 500 milligrams. That is given 1 dose only. Olumiant is another one, which is baricitinib, and that was 4 milligrams given daily for 14 days. So those are the 2 interleukin-6 receptor antagonists, immunomodulators that have been used in this. So there was a condition called cytokine release syndrome. What happens is when the virus is in the system, the body reacts to it, and it releases interleukin-6 in high amount, which gives people shakes, shivers, chills, sudden drop in blood pressure, all of those things. So uske liye, to combat that, tocilizumab was thought to be one of the medications. The other thing here to talk about would be steroids, dexamethasone. Dexamethasone, it comes here as by the name Decadron, 6 milligrams IV, given for 10 days in ICU patients. In some situations when the patient is not getting better, they are on the ventilator, we would give it for 10 more days. Now, I want to talk a little bit about the convalescent plasma or monoclonal antibody. Convalescent plasma, what is convalescent plasma? Convalescent plasma is people who had the infection, their plasma is taken from by doing plasmapheresis. That plasma is transfused into a patient. It already has the antibody in it. It is thought to help the people with the infection or people who have disease. Medications that are not recommended are hydroxychloroquine and chloroquine. And then you might have heard from a lot of YouTube videos and all, lopinavir / ritonavir, which was an HIV medication that was being propagated a lot on YouTube and videos which were coming out of India that they were doing there. Then it was wonderful. And American CDC and all, they do not recommend that. And then there's another medication, you must have heard a lot about it on controversial. Everybody in Pakistan wants to give it to ivermectin. Ivermectin. Ivermectin, which is a medication for given to basically, it's an anti-parasitic medication for parasites. There's a lot of controversy in America also. People want to give it. There is Republicans and some of the people on the right side are saying, why are we not giving ivermectin? We should give ivermectin. CDC has said, do not give ivermectin. Ivermectin should be given only in clinical trials. Clinical trial is where a person who, a number of patients who are admitted to a high-end hospital where researchers work, research scientists work, doctors who are researchers, they work, they can monitor the drugs and their side effects at a very high level. Only ivermectin should be given in those places. There was another thing which was controversial, was vitamin D. Vitamin D should be given only if the vitamin D level is low and you want to replete it to bring the vitamin D level back to normal, but not as some kind of a tonic. Do not give vitamin D. I had also had a lot of questions about people where they were asking about stuff like kalonji or other things like that. I mean, these are all anecdotal evidences that people took kalonji and they got better, and there is no scientific data on that. So how much time? Okay, I think we are at 10:35. I think I will take questions now.
Yeah. Please raise your hand so that it's orderly. We'll give ourselves about 10 minutes for questions and answers. Please ask a question that is very pointed clinically to the lecture that you heard today, and not very simplistic questions. Yes, Mohammed Nawaz. Ji, Mohammed Nawaz, aap, ji.
Yes, sir. So my question is that how much sinusitis was common in these COVID patients? Because yes, sir.
Sinusitis is quite common actually. So what happens is anytime you have nasopharyngeal inflammation and swelling, so anytime you have that swelling, the inner ostia which drain, they become blocked. And anybody who has prior sinus infections also, a lot of people in Pakistan have chronic sinus, they will develop sinusitis. Very common.
Yes, sir. Sir, the COVID is actually an upper respiratory tract infection initially, and it later on goes down into the lungs. So if the treatment includes the treatment of upper respiratory tract infection like nasal rinsing, sinusitis management, I think that would be how you look into this.
Asha, interestingly, there are some ENT surgeons who have made a lot of money, and they are talking about nasal rinses and nasal washes and stuff like that. We don't do that usually in our practice, but outpatient, a lot of people use those. Are they beneficial? To some extent. For sinusitis, mostly it can be a short antibiotic, well, not a short antibiotic course, usually like 7 days of either azithromycin, or you can do any other cephalosporin, second generation orally. You could do it for 10 days. That usually is good enough. Even amoxicillin actually can work in most cases if there's not any kind of resistant or bacteria. But antibiotic with some kind of a medication like a nasal steroid, which will decrease the inflammation inside and make the ostia open up. So that is really the thing to try.
Dr. Sadia Khalid.
Hello, sir. My question is that there is a drug which is available in the market by the name favipiravir. That is an oral antiviral. So is it recommended to give oral antiviral in this course? I mean, remdesivir is already like we have received very good results, but oral antiviral, what is the role of this oral antiviral in this COVID?
Give me the name again. Let me check. I have not heard of this.
Favipiravir, FAVI.
FAVI.
PI
Mhm,
RA
mhm.
VIR. It's cost effective. It's but the course is that like the patient has to take 100 tablets for the course, and a lot of doctors are now using this in Pakistan.
Let me just a second. Actually, this is a question I will probably pose also to one of my infectious disease attendings, and I will probably have that answer back to you because we have not.
That would be perfect, Dr. Shad, and we can communicate back through our WhatsApp group. Thank
Yeah,
you,
because
Dr.
I don't want to give you an answer which is inaccurate. I have not used favipiravir, but I am saying that it has been mentioned here. I think I'll get back to you on this specifically.
Thank you, sir. Thank you.
Thank you.
problem.
Dr. Fiza, you can go ahead with the question, please. जी आप
I didn't hear any question.
जी डॉक्टर फिजा आपकी आवाज नहीं आ रही.
Can you hear me now?
जी.
Sir, I want to ask about the indication of remdesivir in, can we give it as outpatient in the mild disease?
No, nahin. I mean, mild cases may, you want to try to basically treat them supportively. Like, actually, most of the treatment for even for severely diseased patients who are hospitalized is also actually supportive. Most of the treatment is supportive, but outpatient for definite, I would say use supportive treatment. Do not use remdesivir until unless you think the person has a lot of other comorbidities, obesity, COPD, diabetes, hypertension. But remdesivir is never given outpatient in America because you cannot monitor the side effects and problems if they develop. So it's not to be given outpatient.
जी Farrokh.
Hello, sir. Sir, is there any role of nebulization with atom or clanil in case of COVID patients with moderate disease with respiratory or dyspnea?
क्या नाम लिया आपने फिर से कहिएगा?
Nebulization with atom ipotropin or clanil steroids.
Acha, nebulization. Acha, I think I mentioned that a little bit earlier.
And steroids.
I think I mentioned that a little bit earlier. That nebulization was totally disallowed initially. We are doing nebulizer treatments now. आप कोई भी medication उसमें डालते हैं ना, जैसे for example you can have a bronchodilator, ठीक है, which could be duoneb, यहाँ पे कहलाता है, right, which would be ipratropium with albuterol. So you basically have something which is a beta agonist with an anticholinergic combination, ठीक है, and Pakistan में probably combination ये भी होंगे, right? So nebulization में we were not using them. Now we are using that, but there are certain criteria that have to be met. When you are nebulizing somebody, the person who goes into the room to give the nebulization is wearing the PAPR. PAPR is a special kind of a hood and system with negative pressure. They're wearing those, and then there is a notice put outside the room that patient had nebulization. No person should enter the room for 1 hour. Okay, but all of these rooms are now being fixed with special high-powered exhaust fans with a HEPA filter. They are pulling all the vapor, all the droplets, everything from the air into the filter. So if there is, you don't have that kind of facility in the hospital, I would not recommend doing nebulization treatments, because if you give a nebulizer to the patient, you are going to make that whole room full of those tiny droplets. You're going to have major infectivity in that room, and you will have staff members, doctors get that, and that would become a big problem.
Ji Farooq.
Assalamu alaikum. First of all, I must appreciate the whole effort brought by the team, and especially Dr. Abdul Shad, quite informative lecture. I just quickly want to know about the virus shedding period after getting infection from the virus. What is that virus shedding period? It is
Yeah.
it is said like 3 months. If you can elaborate this. And then there is one thing, I don't know, it's medically legitimate to say, like the post-COVID syndrome. Is there anything like that? If it is, so what is the precautions to be taken by the patient, or what should be the advices given by the doctors to the patients? Because many of my patients, because I'm working over here in COVID OPD clinic and using sotrovimab and favipiravir or to all the OPD patients with non-complications. So they are coming on the follow-up despite they have, came out of the COVID active symptoms and their PCR is coming negative consecutively, but still they are having malaise. They are complaining of tiredness, shortness of breath, fullness in the ears, and upper respiratory tract symptoms off and on. So it will be appreciated if you can elaborate this topic, post-COVID syndrome, if it's like that, on virus shedding period. And what if someone can become positive in that particular virus shedding period? Because one of my patients came along with the positive. He was asymptomatic but positive PCR. He was elderly, and my senior told me like he is falling in the range of virus shedding period. So we will not do anything. We'll just treat him on the symptomatic basis.
So yeah, so basically
That's it.
एक तो ये कि
Thank you.
usually 14 days है period जिसमें कि you expect after that they will not be infective, ठीक है ना? After they 18 days, but mostly like 14 days. So if we have a patient at that point, we would consider them not to be infective. Magar shedding ka, there are studies that say that people may carry even the bacteria, the virus in the stool. So they could be infective even later on. They could potentially have virus in their system or their nasal secretions for a longer time. Post-COVID syndrome, jahan tak hai, it's a definite entity. There's very little research on it because this is a new disease. There are no any long-term studies. We have a lot of patients who have shortness of breath, people who have fatigue, muscle wasting, muscle loss. We have people who just are unable to function properly. And this is a major problem, basically, you would have to put patient into rehab, exercises, nutritional support, good. Those are the things that you would need to do. But yes, that's a major problem. We do not have anything specific right now. We do not even have any indication for giving steroids or anything to build muscle back. We don't have any specific research on that at this point. But people will get post-COVID, they have multiple issues. We even had some patients who had stroke and then they needed neuro rehab because they had left-sided, right-sided weakness of the body or something like that. So that is also really common. That is very common. And as far as your patient who was positive later, he said you have to take precautions and not get for him not to give infection to other people. The one who turned positive later in the.
Good question, Dr. Farooq. Dr. Dia, please. Or हम last two questions कर रहे हैं, Dr. Dia and then Dr. Fazal, and then we'll call it for the day. And inshallah, we'll continue on next Saturday as well. जी, Dr. Dia.
अस्सलाम वालेकुम। मेरा क्वेश्चन ये है कि एक पर्सन जो है उसने वैक्सीनेशन की फर्स्ट डोज ली हुई है, तो उसके बाद उसको कोविड के सिम्टम्स हो गए हैं, तो क्या हम दूसरा डोज उसको दे सकते हैं उसी बीमारी के दौरान, माइल्ड सिम्टम है उसके?
Oh, अच्छा. Or he's positive too?
Yes.
That's interesting. Abhi ye sawal actually we recently had asked one of our infectious disease people. So अगर तो symptoms mild हैं और ये तो आप थोड़ा postpone करके दे सकते हैं after a week or something like that. But usually during active disease, it's not recommended to give vaccine. So a very interesting thing happened here. यहाँ पे जो right side पे जो लोग हैं, they were not taking the vaccine, which includes a huge population in the south and some of the nurses. And right now, the people who are getting admitted and the people who are going on the ventilator in Florida state are the ones who never got vaccinated. And everybody on the ventilator in one of the hospitals, somebody had called me and told me that each and every person on the ventilator there was not vaccinated. But now some of the patients who we have who are not on the ventilator, who are COVID positive, who never got vaccinated, they are now begging us to give them the vaccine. So we asked the vaccine people to come in. We have a separate ID infection control nurse who also deals with vaccination. And they basically said that currently their recommendation was that the person, once they get discharged and they're feeling better, then they should come back. 30 days, they were saying, would be the time when they would give it, after 30 days.
Dr. Fazal. ठीक है, शायद डॉक्टर फजल का क्वेश्चन आंसर हो गया होगा. I think we have gone 5 minutes over. Really appreciate this. Inshallah, आप अगर हमारे WhatsApp group का हिस्सा हैं, perhaps most of you are, so stay tuned. हम next Saturday को same time 6:30 Pakistan time, inshallah we'll get together again and continue this discussion. And in the meantime, आपके questions आप obviously prepare कर लीजिएगा. कुछ चीजें हमारी जो questions भी आए हैं medication से related और दूसरी चीजें, inshallah we'll put them together in the form of a slide or two. हम आपको in regular or at least due course of time में आपको हम provide भी कर सकेंगे. With that, I think we thank you, Dr. Shad. Really appreciate everything you shared with us, and you shared your morning with us, on a Saturday. So kind of you.
Thank you.
We are all here, both participants as well as you. If we can save one life with the knowledge that we are sharing with each other, then it's worth the effort. So inshallah, with that intent, we are here. And for participants, please communicate or inform your colleague doctors. This course is really for doctors and physicians, hospitalists. आप उनको inform कर सकते हैं, वो हमारे WhatsApp group का हिस्सा बन जाए, enroll कर लें, और फिर inshallah they can be part of the next lecture and thereafter as well. ठीक है? With that, thank you everyone, and inshallah we'll see you next Saturday. और जो हमारे ultrasound course के students हैं, वो inshallah दूसरे अब उनके पास session link मौजूद हैं, वो they'll be joining us in 10 minutes, but लेकिन उनकी class different है बिल्कुल. ठीक है?
Thank you, Dr. Rauf.
Thank you.
Thank you, Shakir. It was interesting. So.
Thank you so much, Dr.
Thank you.
Okay. Allah Hafiz, everyone.
Allah Hafiz.